Okay, hey guys. I'm going to do one more recording for you. This is going to have to do with our lab that we had today. I know it wasn't optimal circumstances because we were on that big blue button thing instead of in Zoom. So I'm actually going to share a PowerPoint with you a little bit about some of the central line stuff, and hopefully it'll make more sense now when you see it. So let me see if we can get that going. One second. Okay, here we go. So this is a part of a PowerPoint that I did for my other class. I'm not going to show you this whole thing because you don't need the whole thing. Whoops. Let me get back in there. But anyway, I'll show you the portion that talks about central lines. Let me see if I can get in the right spot here. There we go. Okay. So when we talk about central lines are usually going to be inserted into a big vein, like a large vein. So the definition of a central line is a single or multi-lumen catheter that's inserted into your venous system, and it's progressed into the thoracic cavity with the end of the line in the superior vena cava or the right atrium. So typically after they put a central line in, they always check and make sure it's in the right place by doing a chest x-ray. This is to confirm proper tip location and the catheter position to make sure there's not a pneumothorax, because that's always a possibility when they first put it in. Unlike peripheral catheters, a central line, depending on the type, can remain in place for several weeks to sometimes years, depending on the type that you have. Central lines are especially beneficial for patients who have chronic diseases and require long-term IV therapy. So some of the reasons why we might need one would be maybe you have to get TPN, that total parenteral nutrition. TPN typically has really big molecules, like big fat molecules. And so if you try to give it through a peripheral IV line, it just won't handle it. It'll cause you to get phlebitis and cause all kinds of trouble. So you want like some kind of way that you can give it in a bigger bore IV, and usually that works better. So that every time you get TPN, you always have to have a central line. Chemotherapy is another reason why you might want to get this, or maybe some type of really irritating IV solution. This would be the type of line for you because you have a big bore IV and you're not going to feel some of the discomfort from it. Blood products, sure, you could give those through a central line. You don't need a central line just to get blood products, but you know, it's beneficial because like if you're in the ICU or something, a lot of times people are really sick and you have to give them multiple things at the same time. And the nice thing about central lines is that usually they have a lot of different lumens off of them. So you can give like 3 or 4 things in one site, you know, so it's kind of nice. Antibiotics. So again, you don't need a central line just to give antibiotics, but if this is someone who is going to go home on IV antibiotics, then yeah, you would want a central line because you can have it in for a longer period of time. Remember, peripheral lines you can only do for like 3 to 5 days, right? So you don't want to, you know, keep a peripheral line in for weeks on end. So this would be, you know, why you would get a central line. Other things to think about, you know, hemodialysis would be a reason. So remember in class today, we said that usually people will have a fistula in their arm, but sometimes, you know, you run out of good spots. So if you don't have a decent fistula anymore, then maybe you have to put it in the upper chest, and that would be a central line. And then also I have on here central venous pressure monitoring is something that they could do in the ICU if you had a central line. So sometimes that's beneficial. Okay, so here's some pictures of kind of what this stuff looks like. So remember we said there's 4 types of central lines. So the first one is a non-tunneled line. This is a percutaneous central catheter, sometimes called a subclavian or percutaneous acute care short-term catheter. So remember we said that if you were taking care of someone on a regular unit and all of a sudden they started to go bad and you had to send them to ICU, sometimes they'll come in, they'll put a central line in before they send them to ICU. Excuse me. So these types of lines, again, usually they'll put them into like the internal jugular or subclavian vein. And the catheter tip is going to rest in the superior vena cava just above the right atrium. So non-tunnel catheters most often have multiple lumens, just like the one in the picture here. And usually the indications for placement would be, you know, maybe you need to give a ton of different types of IV therapy. You need to, you know, take blood sampling or maybe central venous pressure monitoring. A femoral vein may be used if necessary. And this site is not preferred though, and the catheter should be removed as soon as possible due to high risk of infection. The second type of central line that we're going to talk about is a tunneled catheter. And I know this is hard for me to describe earlier, but I hopefully you can take a look at this picture here. So in the picture, do you see how there's a circle here that shows you like this cuffed portion of the IV line? So when we talk about a tunneled catheter, a uh, it's a tunneled venous access device that's designed for long-term use. So you could have it in for months or years. They're designed to reduce infection without compromising mobility. So this little cuff that's in that circle there, it's called a Dacron cuff. It lies within the subcutaneous tunnel created between the insertion site, you know, of the dermis and the site where the catheter enters the bloodstream. So after they place it, the tissue granulates around that cuff and it anchors it in place and acts like a barrier to the spread of organisms from the skin or the bloodstream. Some cuffs contain antibiotics to further prevent infection. So typically this type of tunneled catheter is going to be used for things like chemotherapy, antibiotics, blood products, and a lot of times it's going to be that hemodialysis or something. So it's going to be like a dialysis port. The distal catheter tip is advanced into the vessel and is placed in the superior vena cava, while the proximal end is tunneled subcutaneously to an incisional exit site on the patient's trunk. The usual exit sites allow the patient to care for them conveniently, while also making it possible to conceal them under clothing. Tunnel catheters are often referred to by the trade names Hickman, Broviac, Leonard, or Brichon. All right, and then this is the med port that I was trying to tell you guys about earlier. So in the picture, you can tell like the back portion of this is flat, and then this is the port itself right here. So this is something that's surgically placed under your skin. So you don't see it outside of the skin at all. There's just like a little bump under your skin. So again, this is an implantable central venous access device. It's often referred to as an implanted port or by the popular brand name Portacap. It's a device placed under the skin without any portion of it exiting the skin. It consists of a single or double injection port with a self-sealing silicone septum covering a metal or plastic reservoir called the body. The catheter connects the port and the reservoir to a central vein, typically the superior vena cava. And an implanted port can be used to administer medication like chemotherapy, to deliver fluids, to draw blood. It does pretty much anything any other site would do. So when we were talking in class, we said this is something that would be really good for someone that was getting chemotherapy. If I was going to get chemotherapy every week or every, yeah, let's just say every week for so many weeks, would you want to go in and like restart an IV in me every week? That would just be ridiculous. So if you had this, they wouldn't have to do that because every time you go in for your appointment, all they would have to do is access this med port. So what they do is you take your non-dominant hand and like say it's here in my upper chest. So I take my hand and I place it right here to like find it, and I'm stabilizing it so it doesn't move. And then I take my dominant hand, and usually you have what you call a Huber needle, and you take the Huber needle, which is at a 90-degree angle, and you put it right in the middle there of this port. As you're pushing it in, it will stop at the back of that port there because it can't go through there. There's no way it'll go through. So it'll stop, and then once you know you're in there, you'll have like a syringe on the end of your stuff, and you can pull back to see if you have a blood return. So the other thing you can do after you have that placed, you will put a dressing over top of it. And the dressing, you don't have to have this sutured in or anything like that. You just put the dressing over top, and then you can use this the whole time they're at the hospital or at your facility. So when they go home, you don't have it accessed anymore. You're going to take it out, so you'll de-access. And again, they'll just have nothing that's attached to them anymore. So the nice thing about these ports is that you can be very mobile with them. You can shower, you can do all of this stuff without having to worry about hurting it. And these can be in for a really long period of time. So this is also a good thing. All right, and then the fourth type of central line is a PICC line. So it's a peripherally inserted central catheter. This is a long central catheter that's inserted into the basilic or cephalic vein in the arm, and the end of the catheter rests in the superior vena cava, just like all the other ones. The PICC line can have a single or multiple lumen, and it is intended for patients who require therapy for several days to months. So this one is not like a super long-term line, but if you were someone who had to go home on IV antibiotics, this would be the thing for you. So if you have a PICC line, you have to be careful because, again, it's not sutured in. You have a dressing over it, but like you wouldn't be able to lift certain things with it. Like if you have grandkids or something, you can't pick up your grandkids because they can mess with it. You can, inadvertently move it, and that would not be good. Also, if you wanted to shower with this, you would have to cover it to make sure it doesn't get all wet. There's a lot of things to think about with the PICC line, so you have to be really careful. Okay, so this just talks about principles of care for central lines. So again, we said if you were flushing this or checking for placement or anything, you always have to have a 10 cc syringe or larger. You cannot use a 3 cc or a 5 cc. The extra pressure from these smaller syringes is going to cause the catheter to rupture if you do that. So you only want to use the 10 cc or larger. It creates less pressure, and it just is a lot better. When you do flush, you are going to flush with usually normal saline, and you want to do it with a pulsating flush. So you push, stop, push, stop. Every time you would access one of these lines, you always want to check and make sure you have a good blood return, and then you always want to make sure you flush really good. If you flush when you're supposed to, like according to whatever your policy is, then this should not clot off and it shouldn't give you any trouble. We have to do what we're supposed to do with it. You never want to flush it forcefully because, again, that could make the catheter rupture. Now, certain lines will require heparin to flush with. So like, for example, that med port that we were talking about, when you deaccess that, you want to flush it with some heparin. So you would flush it with saline first and then heparin last. And that's going to help keep it so it doesn't clot off for the next time that you use it. So the concentration and volume depend on the type of central line and what your protocol is. Like certain ones, like the Grochons, they have a different type of catheter on the end. It has like a valve in it, so you don't need to do that. But yeah, so usually your facility will have some type of policy about how you're supposed to flush each one. So you just have to know what that is. And a lot of times they have a nice little chart that they'll have posted on your unit so you'll know. Again, down here at the bottom, it talks about a valve tip or closed end valve catheter, like a Grochon, that incorporates a valve that opens from positive or negative pressure as is generated by flushing and aspirating. Otherwise, the valve remains closed to keep blood from entering the catheter. So those ones you only would flush with saline. So the other thing I talked to you guys about was clamping. You should always clamp the line if you're not using it. So if a central line is not clamped, you can get air that enters in and into the circulation and could cause an air embolism. So keep the central catheter clamped when not in use. This includes the time in between syringe changes. Use the small plastic clamp attached to the central line for clamping. Catheter with a valve or closed tip such as a Grochon, you don't need to clamp. And then we did mention some complications with central lines. So we should talk about those for a second. So the dysrhythmia would just be only when the catheter first gets placed. Sometimes you'll see someone will have a ventricular dysrhythmia. So hopefully they're on a heart monitor and you could see that if that's the case. So because this goes into that superior vena cava of the heart, anytime you have to do anything has to do with the heart, like where you're right there like that, you can irritate it real easily, and that's why you can see those dysrhythmias. Infection would be another thing, so make sure to use sterile technique every time you're changing the dressing or you're doing anything with that catheter. A lot of places use that central line bloodstream infection bundles. So there's different things, different practices that you do to make sure that you don't have that central line bloodstream infection. Sepsis, this would be something that you would get as a result of having an infection. So if you've got a central line bloodstream infection, it will travel to other places in your body and cause you to be really sick and make you have sepsis. So make sure to discontinue the catheter as soon as possible to reduce your risk of this. And then pneumothorax and hemothorax. So these are complications that you might see upon insertion. Again, because of where that end of the catheter goes, it's right there and it's close to the lungs, you can inadvertently like poke a hole in the lung. And if that's the case, the pneumothorax would just mean that you have a collapsed lung, and the hemothorax is the same thing except you have a collection of blood in that space now. Air embolism. So again, that's something that could happen if you're not clamping the tubing like you're supposed to. So when changing the tubing on a central line, you want to position the client flat if they can tolerate it, and you need to clamp the tubing and have the client hold their breath and bear down while the line is open. So this is basically the Valsalva maneuver. Immediately connect the new line and have the client breathe normally. Because the catheter goes into the thoracic cavity, it's subjected to changes in pressure. which increase the risk for air embolus. So maintain sterile technique when changing connections and tubing. If for some reason you do see someone get an air embolism, what you do for this is you immediately clamp off the line, put them on oxygen, you put them in a Trendelenburg position, which means their head is down low and their feet are up higher. You also want to turn them on their left side, and you would call a physician. So the physician could come and try and, get rid of this air embolism. This positioning kind of helps trap the air embolus so that it doesn't get into the left side of the heart and go out into the circulation. So people, when they have this, it can be pretty scary. You can get this during inadvertent disconnection of the central line tubing if you have a catheter rupture. When you take it out, you could also get this. The patient may develop shortness of breath, chest pain, tachycardia, hypotension, anxiety, nausea, dizziness, and confusion. An air embolism may be suspected if during assessment and auscultation over the pericardium, the nurse hears a churning noise. So that would be another thing that you would look for. Catheter lumen occlusion. So this may be when you go to use one of the ports and it won't flush. So people are lazy. You'll see this when you are a nurse. You'll follow someone and they'll be so lazy they won't call the physician about this messed up catheter, and they will just like tape it off and they'll leave it. And so you'll be like, why won't this flush? And it's because no one's been doing anything about it. All you need to do is call the physician and ask them for an order for a thrombolytic to put through there. So remember, a thrombolytic is a medication that will break up a clot. So if there's a clot in there, it'll break it up and get rid of it so that you can flush it and use it again. Typically, this is going to be Retavase or Alteplase that you put through there. And there's a whole protocol on how to do that. Drug precipitates. This is when you flush with something and you maybe didn't clean out the tubing good enough or something, or the catheter itself already had a little bit of other medicine in it. And if you have two things that mix together that don't mix well, you can get precipitates in the tubing. Pinch-off syndrome. So this is a rare complication of tunneled catheters where the catheter is compressed between the first rib and the clavicle, causing an intermittent occlusion. So if this is the case, you have to remove it and then reposition it. And then catheter malposition just means when you first put in the central line, it's not in the right place. So you would have to reposition it. Catheter rupture, of course, would be if you're flushing and then the catheter just totally explodes because of all of the pressure. So a vascular surgeon would have to be called to go in and retrieve all of those pieces of the catheter through a non-operative interventional procedure they would have to do. So we already talked about air embolism. And actually, I think that's it, because this gets into other things now. So again, just kind of review this a little bit. And then when we go back to campus in August, we'll kind of practice some of these things and hopefully it'll make a little bit more sense. So at that point, we will do a central line dressing change, and we'll also practice accessing and deaccessing a med port. If you guys have any questions, feel free to ask. Hopefully this helped you understand it a little bit better.